are honored today to have our guest speaker, Dr. Keith Barton. Dr. Keith is a world-renowned glaucoma consultant. He is the director of the glaucoma service at Moorfields Eye Hospital, the famous Moorfields in Britain. Dr. Barton has been an active participator in the conferences of the Egyptian Glaucoma Society in several past years, and we were honored to have him physically in Egypt several years earlier. Dr. Barton has published several tens and maybe hundreds of publications in the field of glaucoma, as well as authored and co-authored a number of books about glaucoma, covering all fields of glaucoma, focusing mainly on uveitic and refractory glaucomas, as well as minimally invasive glaucoma surgery. We are honored as well to have as a speaker tonight our honorable professor, Professor Tariq Eid from Tanta University. Professor Tariq has a special interest in glaucoma after vitrectomy procedures and has published a number of publications about glaucoma worldwide. Our honorable speaker as well is Professor Ahmed Khalil from the Research Institute of Ophthalmology, and Professor Khalil is our head of the Egyptian Society of the Glaucoma, and we are really honored to have him as a speaker today to share with us his vast experience in the field of glaucoma. So now we would like to go into the topic straight away, and we would invite Dr. Keith Barton to deliver us his excellent talk about uveitic glaucoma. So, Mr. Barton, please take the lead. Thank you very much, sir.
Thank you very much. It's always a pleasure. It's very sad not to actually be in Egypt. You know, I hope you can hear me clearly.
Very clearly, sir. Please.
I've been in Egypt many times, as you know. I think 13 times when I counted it last, and it's always a pleasure because of the immense hospitality of the Egyptian people. And uveitic glaucoma is a topic close to my heart. It's a difficult glaucoma because everything is exaggerated in uveitic glaucoma compared with open angle glaucoma. When the pressures are high, they're extremely high. When they're low, they're extremely low. The treatment can put the pressure up or down, and the disease can put the pressure up or down. So it can be a very confusing. It can be a very confusing situation, and you know, there are a number of mechanisms that might put the pressure up, such as steroids, inflammation, angle closure, fixed viscous aqueous in some patients. And there are a number of mechanisms that may reduce the pressure, largely with one common mechanism of lack of aqueous production of the ciliary body. And you often end up in a situation where there's very, very little aqueous outflow or none at all, yet the pressures can be very high because yet the pressure can be low because there's no aqueous production. On the other hand, you can have an eye where there's very, very little aqueous production, but a very, very high pressure because there's no aqueous outflow. So it is a condition, a mixture of conditions that is very challenging to treat, as I'm sure you well know. One particular issue with uveitis is its propensity to cause angle closure, and sometimes very acute angle closure in very young patients. This was a case of tuberculous uveitis with, as you can see, acute angle closure, very, very plasmoid, thick aqueous, and pupil block. And angle closure in uveitis is very different from primary angle closure. It occurs in 3 different ways. You can have patients with pre-existing narrow angles, or simply coincidental angle closure. They could just be unlucky and have uveitis and narrow drainage angles, which can of course occur. Or they can have an acute pupil block from posterior synechii. Or you can actually, in acute anterior uveitis, get relative pupil block. But interestingly, in acute anterior uveitis, even with relative pupil block, the pressure often goes down rather than up, which is the paradox. On the other hand, you can secondary angle closure from inflammation, nodules, neovascularization, membranes in the angle, or you can get forward movement of the lens iris diaphragm from either posterior scleritis or some sort of surgery of the posterior segment, or phacomorphic causes. So there's a mixture of mechanisms that make it particularly interesting and particularly challenging. the pupil block, the chronic angle closure, the central angle anterior chamber shallowing mechanism, and all three have different etiology and treatments. Pupil block's particularly interesting. Now this is relative pupil block in primary angle closure. That's the sort that we see, in elderly hypermetropes, and it's not something it's something that we think is particularly dramatic, but it's nothing like as dramatic as the acute angle closure that you get in uveitis when you get pupil block. Remember, in uveitis, when you get pupil block, it can be in a pseudophakic eye or a phakic eye, and not only do you have relative pupil block, but absolute pupil block. There's absolutely no aqueous getting through the pupil, and the iris balloons forward in very dramatic fashion. And you can see, unlike primary angle closure, in uveitic pupil block, the angles, the iris is right against the cornea, and you don't really see this usually in primary angle closure. So this is a much more dramatic, condition. And you can see another difference between this and acute angle closure is the very thick, sticky aqueous. And you can understand why in these cases that laser iridotomy is actually pretty useless. Everyone tries to do it. For instance, you can see this patient, someone's tried to do 2 or 3 laser iridotomies, but in fact, it's been totally useless. You can see the iris is right against the cornea, except through this small area. So this is very, very different, and it shouldn't really be mistaken for primary angle closure. And it also occurs in young people, younger people in primary angle closure, and they go blind, they go no light perception if this is not treated properly. It's very important, therefore, to look at the angle. Bridging synechia can occur after an acute angle closure attack. These are very characteristic, but maybe not of that much clinical consequence, because often they occur after one attack of severe anterior uveitis and may not really herald a long-term pressure problem. But if you see an angle like this where there's anterior synechia everywhere, especially if the patient's not had any surgery, you know that this angle is compromised. This patient's pressure problem in uveitis, which might be episodic, is never going to go away, and you really need to think about a surgical option. On the other hand, this patient with a wide open angle, if they're suddenly getting high pressure, perhaps this is actually a steroid response, and maybe you can temporize with medication until the steroid response comes under control. You can see they've got a bit of pigment in the angle from the uveitis attack. It's not much, and this angle's wide open. On the other hand, this patient with sarcoid nodules in the angle, you can see here, this is completely different. This is an important diagnostic finding, and you sometimes see the synechia developing around the sarcoid nodules, and this patient had 6 or 7 of these all the way through the angle. And these are important to pick up because this was a young black man, and these nodules are an indicator of the sarcoidosis. So it's actually potentially diagnostic. So angle closure can be due to 3 factors. The forward movement of the lens iris diaphragm is probably the least common, so I deal with it first. Differs dramatically from pupil block. This is pupil block. This is forward movement. You can see here pupil block, very deep anterior chamber. Forward movement, lens iris diaphragm, no anterior chamber in the middle. Lens is almost against the cornea. And in this particular situation, it might be aqueous misdirection. It might be from vitrectomy and gas. It might be from posterior scleritis. It might be from a very high buccal, which we rarely see these days. Or it might just be an incredibly big swollen lens. But either way, you've got to fix it. And once you fix this, once you understand the problem, then the correction is easy. Chronic angle closure, as I mentioned, is very often really a predictor of a long-term problem rather than an acute thing to correct. Obviously, you cannot fix chronic angle closure. Goniosynechiolisis in these cases is damp, traumatic, and of no clinical benefit. Pupil block, as I mentioned before, is the most dramatic. It's more common than lens iris diaphragm problems, and it's the thing that we get wrong the most, and that's why I go on about it. It's uncommon, potentially devastating, although other angle problems are common. Laser iridotomy is often a waste of time in these cases and delays treatment. This is an example of not somebody where that was such an issue, but it illustrates why this does not work. This is a relatively quiet eye where the patient got acute angle closure, and when even though her pupil wouldn't move and wouldn't dilate, when I put in dilating drops, she actually lost Bombay in 2 quadrants because there was a tiny little bit of aqueous getting through in one place, but not anywhere else. And normally you would expect aqueous to get through the pupil to go all the way around come all the way around the iris, but it didn't. Because this lady has very loculated aqueous, so you get Bombay in 1 quadrant, but not the other. And again, Bombay in the top superior quadrant, but not inferior. So dilating the pupil shifted the iris a little bit and relieved Bombay in 2 quadrants, but not 4. In fact, in this lady, because her anterior chamber was relatively quiet, I did phacoemulsification rather than anything else. But phacoemulsification is not appropriate for patients with very hot eyes, obviously. But the posterior chamber is not a continuous space in these people. They have broad adhesions between iris and lens. And you can see on OCT what it looks like. You can see these adhesions, the thick iris. You can see why laser iridotomy wouldn't work here. Firstly, you've got this great big spongy iris to get through, and then you probably get through to this one bubble and not burst here. So you're not really fixing the problem with laser iridotomy. So why then would surgical iridectomy make any difference if laser iridotomy doesn't? Well, the difference with surgical iridectomy is that you can actually relieve the synechiae if they're not permanent. And here's an example of why laser iridotomy is a waste of time. This patient has got 3 laser PIs, all patent. The Bombay has gone, luckily enough, but the angle is completely closed. So by doing a laser iridotomy, they missed the opportunity to open the angle. It got rid of the Bombay, but remember, if there's a lot of fibrin holding the trabecular meshwork and iris together, then laser iridotomy will not get rid of these adhesions. They are reversible adhesions in the early stages, and you can remove them with viscoelastic in the operating theatre, but you cannot remove them with laser iridotomy. And this was shown in this paper by Betts et al. In the BJO earlier this year, and we did, Gary Holland from UCLA, a uveitis specialist at Jules Stein Eye Institute in University of California, Los Angeles, did this editorial with me discussing this. One of the reasons that this is the patient who had the 3 attempted iridotomies. So in the operating theatre, the first thing is it's very difficult to mobilize the iris. And this helps you understand why iridectomy might not work. And you can see that I spent a long time using viscoelastic to separate the iris from the cornea. Not separating the iris from the trabecular meshwork even, just separating it from the cornea so I could get into the eye. And then when you get in, you've got to try and mobilize the iris enough to do the iridectomy. And this actually was a very abbreviated video because I couldn't actually mobilize the iris without a lot of viscodissection, so it took about 15 minutes. But eventually I did an iridectomy, and that relieved the problem. This was more than 10 years ago, and I'll show you later how I would do it nowadays, which would be completely different. But in certain circumstances, depending what instruments you had, this is still sometimes the best way to do it. But you can see I still can't get the iris, and eventually I made the hole bigger, and eventually I did the iridectomy, and you'll see later how I would do it nowadays. Obviously, very different, and with more viscoelastic, you get the problem is the iris is actually stuck to the cornea. I'm just trying to get the iris back so it actually make the wound slightly bigger, just to get more, just to try and permit more iris mobility. I think the forceps are in the wrong way around there. and still it won't come. And this isn't just lousy surgery. These are just very difficult to mobilize. And eventually a patient gets an iridectomy. Well, that's not very impressive, is it? You know, why go to so much trouble and take so long? Well, I'll show you a little bit more. You then have the opportunity to break the sneaky eye, posterior sneaky eye. Now you can see that this type of uveitis causes angle closure even when the patient's pseudophakic. But doing this can be, you can do this through the iridectomy and come out from behind, but this could be very traumatic, and you can see there's bleeding from the iris root. So it's not always worth doing. If they don't break easily, then don't do it, because you can actually cause a lot of trauma, and it's unnecessary. But on the other hand, what you can do that's very useful is you can take Helon and you can open up the drainage angle. Often in these cases, the drainage angle is reversibly closed with fibrin. It's not sneaky eye, it's just fibrin, and you can break them using using viscoelastic. And you can, this is how you open up the angle, and this is what you cannot do with laser iridotomy. You just go round and you separate the iris. In primary angle closure, you wouldn't need to do this. The iris just falls back when you do the iridotomy. But in uveitis, it does not. It stays stuck, and the adhesions become permanent unless you break them. This is not true goniosynechiolysis. This is only viscoelastic, and this opens it up. And then the easy way to do an iridectomy, this is how I would do it nowadays, is not go in at the front, but use 23 gauge vitrectomy forceps and scissors. This is an expensive iridectomy, but it's a much easier way to do it, and you can get a clear corneal view. You're not obscured, and you can do these little 23 gauge. You can use 20 gauge scissors as well. Probably get, you don't have to make so many bites, because the 23 gauge are a little fiddly. You have to cut quite a number of times to get a decent iridectomy. And then you end up with a little tag of iris, take the instruments out, reverse them around, and do it the other way and cut off the tag. And this is a more elegant way to do the iridectomy. But the key isn't even the iridectomy. The key is especially the viscoelastic and the drainage angle. That's what you're doing differently that you can't do in laser iridotomy. So then you don't end up with this, where there's patent iridotomies and a completely closed drainage angle and a chronic high pressure. You have the chance to prevent this happening if you do the iridectomy. So it's a difficult thing. Angle surgery in general is ineffective, and it's traumatic for chronic synechiae. However, it isn't always useful. It can be useful in young people with open angle. This was a 23-year-old Canadian in childhood and didn't need a tube for 15 years. She did need a tube, but it was 15 years before she needed it. On the other hand, Ho Ching Lin in Singapore showed that goniosurgery had a negative impact if there were anterior synechiae. So it's important to identify the mechanisms. Chronic synechial closure is useful for risk profiling, but it's not so important. Surgical iridectomy is preferable to laser, and there's a lot to see in the angle. What about open angle? When do we operate? Now, these are patients who very often need surgery. SLT is not enough. MIGs are generally not enough. You're really tinkering if you do these, you know, these patients have pressures of 40 or 50. And you only do SLT if you're trying to make money, because you're not helping the patient. So IOP uncontrolled on Diamox, that's a definite indication for surgery, unless the patient refuses. Patient needs chronic Diamox, well then that's an indication for surgery. Optic disc asymmetry is more like a predictor of people who will need surgery than an absolute indication. But if you have a 23-year-old who's starting to get optic disc asymmetry and the pressure is high, then it's time to think about surgery. This is not primary open angle glaucoma where you wait until their disc is 0.9 before you have surgery. We are operating here in normal discs because the patients have pressures of 40 and 50. And if you don't fix it, they will have very bad glaucoma very quickly. If they have progressing visual fields and the other indications for surgery, obviously as well. The predictors are widespread angle damage, optic disc asymmetry, especially in a young patient, and some types of uveitis have just got a high rate of IOP elevation, independent of steroid use, and it's especially the infectious uveitis, and these require glaucoma surgery. And the typical ones are Fuchs, who we still see quite a lot of, herpetic keratouveitis, and patients such as Posner-Schlossman syndrome. Posner-Schlossman syndrome, which is obviously a sudden episodic condition, don't always need surgery, obviously, but they do have very high pressures, and they're starting to get optic disc damage, then you ought to think about surgery. Fuchs is particularly interesting because it's often misdiagnosed or missed, treated with steroids, which are of not much benefit. Glaucoma potential underestimated. They see retinal surgeons who do floater removal, vitrectomy, but don't appreciate the risk of glaucoma, and commonly causes recalcitrant glaucoma requiring surgery. And filtration surgery is generally a little bit less effective than other uveitics. And this is a video that I started to put together just to show the whole spectrum of Fuchs. This is not online yet. And it's characterized typically by heterochromia. You can see the difference between the two eyes here. And we'll look into that in a little more detail in a moment. The KP are typically all over the cornea, and everyone focuses on the KP and their even distribution and their funny spindly appearance. And you can see these funny little strands between the KP on retroillumination here. Long-standing KP might be like, you know, a spotty cornea simply. But the clinical features vary extensively. And look at this, this transillumination of the iris. You know, these patients have blue-eyed Fuchs patients who maybe don't see so much in Egypt have loss of the pigment epithelial layer of the back of the iris. It's quite dramatic. It's very evenly spread around the periphery. It's not at all like pigment dispersion syndrome or the pigment loss you get in other types of uveitis. And you can see in this particular extreme example, there's the typical pupil margin membrane that doesn't seem to cause sneaky eye, and still the pupil reacts. And despite the chronic inflammation and despite the pupillary membrane, the pupil reacts and sneaky eye don't develop. And interestingly, unlike other types of pigment loss, you don't seem to see pigment in the angle. This angle is pure white despite a lot of pigment loss from the iris, which is unusual. And you can see these unique solitary vessels, which are very typical of Fuchs. Just here, the arrow's not always so easy to see. Most of the time you don't see them. They're fairly rare, but I want to show you now a selection of them that are quite dramatic, because I've seen an awful lot of Fuchs cases. And these are very different from neovascularization that you would see in diabetes or retinal vein occlusion. You can see they're typically isolated. Rarely do you see multiple ones like this, and rarely are they so dramatic, but I'm just showing a few interesting cases. And very, very occasionally you will see them bleed, and this is what is notoriously causes hyphemas after decompressive surgery in Fuchs. And you see they're very, very dramatic. So the diagnosis of Fuchs is more than just KPs. There's a lot to see here, and these are rarely this impressive, but as you can see, sometimes they are, and it's only the occasional patient where you'll see this many. The blue-eyed Fuchs, typically, you can see the Fuchs iris is typically thinner with less stroma. It's almost like a congenital abnormality nearly. The Fuchs iris, the normal iris is much juicier and thicker and fluffier. The Fuchs iris is often more featureless, and this is how you tell the difference. But the dark eyes that maybe more often see in Egypt are more completely different. The irises are not thinner, and they do have these nodules, which are quite often very symmetrically distributed, and often all the way around the pupil, at the pupil margin, or away from the pupil. It's very interesting, the wide spectrum of Fuchs. So and also the last thing to mention is the floaters. As I mentioned, I don't see these anymore, but I used to see them come. They'd have a vitrectomy for floaters, and the retinal surgeon didn't appreciate the risk of glaucoma, and they weren't really monitored afterwards or warned then they get very bad discs and a pressure of 40. So you've got to watch out for Fuchs and other types of uveitis that might be infective. They are at a higher risk of glaucoma. Filtration surgery. What do? Tubes, trabs, something else. The reason we set up a uveitic glaucoma clinic at Moorfields was that uveitics had a bad history from trabeculectomy. They just didn't work. And why was that? It's because they ended up in the glaucoma clinics after the trab and didn't get looked after by the uveitis specialist properly. Tubes do work well in uveitis. Ask any glaucoma specialist in America. They do tubes, at least in the tertiary referral center. So you've got a private practice, they just do SLT, which doesn't do anything and it's a waste of time. But in the tertiary referral centers, they do tubes because tubes work in uveitis. But you don't have to do tubes in uveitis. Trabs do work in certain types of uveitis in very well-controlled circumstances. And you need to be controlling the intraocular inflammatory episodes and controlling the conjunctival inflammation. And you have to ignore the cataract and concentrate on the pressure. Even if there's a bad cataract, you can't see the disc. If the pressure's high, don't take out the cataract, fix the pressure, take out the cataract later. This is a 16-year-old with hand motions vision from cataract. The pressure's 40, fix the pressure, do the cataract later, no matter how much the family wants you to take out the cataract. There's a great fallacy that cataract surgery comes first. This is a big mistake. And I've seen young people go blind in the eyes where cataract surgery has been delayed and no one looked at the optic disc. Fix the pressure, then you don't have to worry about the disc. Trabeculectomies work well, but they have a higher risk of hypotony, so you simply put more stitches in the flap. We use releasable sutures because they're easier to work with than laser suture lysis. Laser suture lysis means you gotta find the key, open the laser room, log into the laser. The computer doesn't work. We're not allowed to use it without logging into the computer. It's a whole long thing. Laser removable sutures you can take out of the slit lamp in a second. And using, 10 years ago, we audited these with 199 uveitic trabs. Success rate at 4 years, which was roughly the median in this, was 82%, I think. But lens status is vitally important. Phakic eyes do better with trabeculectomy than pseudophakic eyes. You take out the lens first, not only are you causing the pressure problem to persist, but actually you compromise the later trabeculectomy. And what you don't want to do is take out the lens first and then be forced to do a trab soon afterwards because it'll just fail. Do the trab, let the eye settle down for 6 months, treat it well, and then take out the cataract. You don't need extra steroids for a trab. You do need them for a cataract. Cataract's far more inflammatory than a trab. What about MIGS? In patients who are phakic or have had no previous surgery, who don't have juvenile onset uveitis, subconjunctival MIGS actually work quite well, especially white people. In high scarring ethnicities and maybe in Egyptians, they wouldn't work so well. But certainly in whites who haven't had a lot of glaucoma medication, the Zen actually worked quite well. And we wrote up a series of these in the clinical experimental ophthalmology. The InFocus microshunt seems to be similar. It's an ab external procedure rather than ab internal procedure. It seems to have less postoperative needling and so forth and less early hypotony, but similar long-term results. And we presented a series of these at the American Glaucoma Society in Washington in February, just before the pandemic. What do I do when? No failure risk factors, high pressures, relatively healthy discs. I actually do subconjunctival MIGS because these are young patients and the subconjunctival MIGS are not too invasive. But if they have no failure risk factors and their pressures are high and their glaucoma is bad, then I do a trab. These people need to have their optic discs preserved. And young people with bad discs need to be treated more aggressively than old people with bad discs. So that's it. No risk factors. Risk factors for failure, forget all of this. If there's any risk factors for failure, tube. That's ethnicity, pseudophakia, single chamber. Pseudophakia is a mild risk factor. neovascular. Some types of conditions don't do so well with TRABs. I found that JIA, I never TRAB. VKH, Behçet's, and Fuchs don't seem to do quite so well with TRABs either. But in terms of the higher failure rate, it may be worth considering tubes. Tubes traditionally have a long history of good efficacy in uveitis. Ironically and surprisingly, tubes work better in uveitis than they do in anything else. What about the long-term risk of hypotony? Instead of a long-term risk of failure, people worry about long-term hypotony with tubes in uveitis. And for certain types of uveitis, juvenile, any chronic severe uveitis from early childhood, or congenital cataracts that were needled in early childhood, I do a smaller tube. I don't do a 350 Barvelt. I do a single plate Maltino or a Barvelt 250, although those conditions you could do an amide valve. The other types I wouldn't do an amide valve, it's just not effective enough. The single plate Maltino is still useful in cases where there's a low aqueous production and a high risk of hypotony. An important point is don't reduce the steroids to reduce the pressure. You need to treat the pressure surgically. You need to keep the uveitis under control. And if you need steroids to keep the uveitis under control, then treat the pressure surgically and use the steroids to keep the uveitis under control. By all means, send the patient to the uveitis specialist who can give them Humira, infliximab, methotrexate, other drugs, but don't reduce the steroids just to reduce the pressure. Chronic grumbling uveitis makes things worse. Treat the uveitis aggressively with whatever treatments required. Control the pressure surgically as required. Acute angle closure, surgical, not laser iridectomy, and visco to the angle to open it up. No failure risk factors, high pressures, mild glaucoma, mild disc asymmetry, Zen or in focus. No failure risk factors, high pressures, bad discs, TRAB. Significant failure risk factors, then tube, depending on age, severity, and chronicity of uveitis. And there's more videos in these websites, and that Fuchs video will be finished at some point. And thank you very much for your attention. I'd be happy to answer any questions if there's still time, if I haven't talked too much.
No, that was a very, very great presentation, sir. We thank you very, very much for this excellent and very informative presentation, Dr. Keith Barton. Thank you very much. And if you would have the time to answer a few questions, please, we would be delighted.
Oh yeah, plenty of time.
Okay, thank you very much. Let's say the first question would be, would you put it as a condition that uveitis must be under control before you would operate surgically, or would you operate surgically in an actively inflamed eye?
This is a good question, and it's always one that's difficult to answer. One thing is that we have the luxury of a lot of uveitis specialists, and a lot of the patients that I get from them are heavily treated. If you've got a lot of uveitis specialists, you get uveitis that's treated aggressively. And I think as glaucoma specialists, we're never quite sure how aggressively to treat it and what to do. So I think if you get a uveitis specialist on board and you treat it aggressively, you will be asking yourself that question in a much smaller number of patients. But there are some patients where you just have to, the pressure's 50, you've got to do something. You need to move in and do it. And
so we can intervene in an actively inflamed eye.
It's in general, you're talking about eyes where there's a small amount of chronic inflammation, not a heavy amount. If there's a heavy amount, you really need to hit it heavily with steroids and intervene. In those situations, tube is a better option than other types of surgery because tubes basically survive in more difficult circumstances than any other type of surgery does.
Okay, if sir, as you've mentioned, we have an efficient uveitis specialist who's going to control the inflammation, and let's say we have the inflammation controlled. Would you set a time limit before you would intervene for surgery, or this will depend on the degree of compromise of the optic nerve, of course?
It does a lot. I mean, if you have to probably, you could try wait a month or something. That's typically what we, you would like. In an ideal world, you would like the uveitis to be quiet for 3 months, but that's often not.
It's not always possible.
Yeah. So you say if it's quiet for a month, then The one thing to point out, I find, we've had a long-standing practice at Moorfields. We don't increase steroids for glaucoma surgery. We increase them for cataract surgery. Cataract surgery has a much more profound inflammatory effect inside the eye than glaucoma surgery. So we never, I notice a lot of my colleagues do, but it's not necessary. We don't increase the steroids for tubes or trabs. We do for cataract surgery. If it's well controlled, you can usually do the tube or trab without worry. The cataract surgery is far more inflammatory.
Okay. When you addressed, sir, focusing on the pathology in the angle and gonioscopy, would you go for a goniosaniculitis or even with viscoelastic during a trab, or you would defer it to at the time when you're doing the cataract?
No, I wouldn't do it during the cataract or the trab. I only do it when there's acute angle closure. Because if it's acute angle closure, the sneaky eye have only been there 1 or 2 days, and then you can break it gently with visco. If you're doing it when it's been there for months, then all you create is bleeding and more scarring. So it's just a waste of time. So when you're doing the cataract, it's unlikely that you just got the sneaky eye yesterday or the day before. It's been there for months, and then you just create bleeding, more scarring in the meshwork, worse pressure control.
So even under direct intraoperative gonioscopy, you would not attempt to do the goniosaniculitis with the cataract because it's been there definitely for a long time.
Yeah, it's been there a long time. You're just damaging the angle more. The people, it's kind of funny, the people in whom goniosurgery works best are the people who have no sneaky eye.
Maybe it's the inflammatory membrane over an open angle or gonioscopically open angle.
And typically children, not adults.
Sure. Having mentioned that we may need to operate an acutely inflamed eye, occasionally, let's say. So there are times maybe that you would operate and you would know that this filter or this whatever glaucoma surgery is up to fail in the near future. Would you take any precautions to open a small surface area of the conjunctiva to operate, or will you do your standard glaucoma procedure, be it tube, be it a trab?
I tend to do the standard procedure. In that situation, I would be aggressive. The patient would get systemic steroids probably, rather than you can use intravitreal triamcinolone if you're worried about macular edema, but if you're really worried about inflammation and it's heavy, then I will use probably systemic steroids.
Not macular inflammation, sir. If I'm doing a filtering surgery in a uveitic, that I know that this surgery is going to fail because of ongoing inflammation, and I know that I will need to repeat it. So what would you recommend, sir?
You can minimize the risk of it failing, but literally, if it's very inflamed, by systemic steroids beforehand. Or probably, we use Avastin sometimes as well, because, Avastin's become popular. Avastin is mildly antifibrotic. It's not strong antifibrotic, but if you're using mitomycin and Avastin, you get a bit more antifibrosis. You get a slightly better chance of it working. We don't really know how effective that is, but we think it gives a little bit of benefit. So you may be able to save it with systemic steroids, or typically what I would often do is give orbital fluor triamcinolone, 40 milligrams of orbital fluor triamcinolone, intracameral Avastin, and high dose of.
Or subconjunctival Avastin, or intracameral, subconjunctival or intracameral?
No, I put it into the AC, because you really want it going through the flap and hitting the tissues there. I mean, ideally you would put it in the vitreous, but intravitreal injection is more invasive, so I always put it in the anterior chamber.
Okay, when we use steroids here to preserve the filtering surgery, have you encountered, sir, any cases of cystic blebs or thin blebs with such procedures, or it's not that much? Not
thin blebs. There's always the concern that steroids do promote fibrosis to some degree. They reduce. It's a two-edged sword. They reduce inflammation, and reducing inflammation stops the fibrotic stimuli. But on the other hand, we know that they affect the cellular matrix, intracellular matrix, extracellular matrix, and the cellular cytoskeleton, and promote fibrosis to some degree as well. So there is a kind of a mixed effect from steroids. Certainly, in the high-risk failure cases, I will give 40 milligrams of triamcinolone below to the subtenones under the orbit, because that will give the patient 2 or 3 months of quiet eye, especially if I think the patient may be poorly compliant.
Okay. Almost, I know it will depend on the clinical situation, but let's say, what's the average timing or circumstance when you would start considering removal of releasable suture in a filtering surgery in a uveitic?
It
Around,
really,
I mean, what are the
yeah,
indicators?
this is tricky.
I'm sorry.
Sometimes, my biggest cause of hypotony is pulling the stitches too quickly. And what happens, of course, is, the pressure's 30 or post-operatively, so you get excited and you pull the stitch and then it's too low. Exactly. So you do have to temper that. I will do a lot of massage to start with. I will massage the bleb down to 10 or 8 or something, sit the patient outside for 20 minutes, bring them back in, massage it again, bring it back to, if it keeps going up, do that 2 or 3 times.
Sure.
If it's still really persistently high, then I will pull out a releasable suture. But sometimes you have to even do that in the first week. Ideally, you don't do it in the first week. You wait a couple of weeks.
Okay, so you're speaking of 3 to 4 weeks on the average, let's say. And the mitomycin gives...
Yeah, 2 to 3 weeks probably the most effective. After about 4, you do get an effect in some people, but a lot of people by 4
have already scored.
Yeah.
So already too late. Yes.
Yeah.
Okay. So we have this question from the attendees, sir. What about the idea of removing the synechiae, goniosyneculasis, and then do an incision in the angle like with the KDB at the same session, Kahook dual blade?
Well, there's no real evidence that the KDB works. It's heavily promoted and it's heavily reimbursed in the United States. But we're waiting to see some data.
Okay.
And if you've got synechiae to start with, you're just causing more trauma.
Okay. So, and then we finish with our question from our close friend and yours, Dr. Ahmed Yusr Al-Qarmouti, and he's saying hi, and he's asking, would you could agree that the prophylactic surgical iridectomy in an eye that has almost complete but not 360-degree occlusio is worth considering? A prophylactic surgical iridectomy,
so
maybe with the technique that you described, sir.
So Gary Holland, Gary Holland at Jules Stein is the guy who discovered CNV retinitis. He's an absolute guru of uveitis. And the reason we got together in some papers is we found we had very similar views on things. But one thing that he has a view on that I'm not really qualified to say is he says, if the synechiae are almost 360, don't laser.
Okay.
So he says don't do it, because what he says is that tiny little bit left, the aqueous going through that is probably just keeping that hole open. And if you do a laser and you divert the aqueous through the laser hole, then that last little bit might close. So he says don't laser. I don't know, we don't see enough of these cases we're not seeing hundreds of these cases to say, well, this is what you should do and this is what you shouldn't do. And each case is individual. Excuse me, but I was starting to get, Carlos Pavesio, my colleague in uveitis, would often refer me cases actually for doing surgical iridectomy in that situation. And I don't know the answer. Sometimes we do them, sometimes we don't. But Gary Holland feels very strongly that it's the wrong thing to do.
It's the wrong thing to do a laser iridectomy.
Yeah.
But
he thinks you should not laser or do prophylactic surgery, because that little tiny bit of aqueous going through that last little gap is keeping that little gap open. That's what.
Yes, I agree. And when you do the surgical iridectomy, sir, do you inject viscoelastic through it to break the locules and the synechiae between the iris and the rest of the lens?
Yeah, I didn't show that in the video, but I do. You've got to be careful though, because as I tried to show, you can really traumatize the iris root if you're not careful.
A lot of bleeding.
These adhesions, these are not just little adhesions, these are really tough. And especially the pseudophakic eye. In the pseudophakic eye, the iris just sticks to the anterior lens capsule and it's really, really stuck. In the phakic eyes, it doesn't tend to be quite so bad, but in the pseudophakics, it's really tough.
Okay. So we thank you very, very, very much, Mr. Barton, for this excellent presentation and for helping us with the questions. Thank you very, very much. And we really wish to have you physically and personally with us in Egypt in the very near future. Thank you very much, sir.
Always happy to come back to Egypt.
It's our delight and honor, sir. Okay, thank you
Thanks.
very, very